Hello everyone, this is Dr. Ochoa, your Pathway to Wholeness Medical Director. Today we'll be covering the subject of sleep, and by the end of this discussion I hope to be able to convey to you the importance of this topic as a pillar of health. It is one among 6 subjects which form the core areas of clinical focus in lifestyle medicine. We will cover the following: some physiology, the stages of sleep, what factors determine good sleep, the consequences of inadequate sleep, and how to assess problems related to sleep and what we can do about it. With that said, let us begin. Can 1 hour of sleep deprivation harm you? Let's look at this study, 2019 meta-analysis of greater than 115,000 persons that looked at spring daylight savings time with the consequent 1 hour loss of sleep and an observed increase in myocardial infarction risk that was substantial in relative risk terms, 66% increase in risk. Another observation around spring daylight savings time is a 6% increase in fatal traffic accidents in the United States. So how does this happen? So according to the AAA Foundation for Traffic Safety, drowsy driving likely influences 16 to 20% of fatal car crashes. What makes us sleepy? Let's look first at the most intuitive aspect of sleepiness, and that is so-called sleep pressure. So our irresistible sense of feeling so tired we have to rest is driven by the accumulation of this chemical called adenosine. Adenosine accumulates in our brain while we are awake, and while we sleep, we rapidly decrease the amount of adenosine that is in our brain, so we get rid of it. It's an interesting fact that caffeine actually competes with adenosine at the relevant receptors in the brain. So this is a factor sometimes, of course, impairing sleep. The less obvious factor that drives our sleepiness is our so-called circadian rhythm. So all of us have this cycle that lasts about 24 hours. To be clear, this is a cycle affecting wakefulness and sleepiness that lasts approximately 24 hours. There's an important structure in the brain referred to as the suprachiasmatic nucleus, and it serves as something like the master clock of the brain. There are cells in the back of our eye, the retina, which acts something like the satellite dish of one's eye. And these light signals are transmitted to the suprachiasmatic nucleus, which in turn then communicates to other relevant portions of the brain and ultimately body to inform us of this cycle. There are 2 other factors that are here mentioned in this slide that are under the governance of this circadian rhythm, and one of them is melatonin production. So melatonin production begins to increase as night begins and eventually falls off early in the morning. And basically this acts as a signal for nighttime. So it doesn't necessarily make a person sleepy, but it does inform us that night has come. Another factor under circadian influence is our body temperature, which begins to drop as we're getting sleepy by evening, and then early in the morning we warm up. If you look at this graph from left to right, first notice in blue the sleep pressure on the left-hand side increasing. As sleep eventually ensues, you see this decline in subsequent sleep pressure because your brain begins to clear the adenosine, and then by early morning you no longer have the sleep pressure and your natural circadian rhythm is waking you. So when everything is working right, we should experience consistent sleep and wake cycles. So each of us has this approximate 24-hour circadian sleep cycle, but of course not everyone likes to get up or go to bed at the same time. We have, each of us, a preference, and this is referred to as our chronotype. So-called morning types account for about 40% of the population, where Evening types, including myself, account for about 30% of the population. Now, importantly, and this is really key to observe, it's that circadian and sleep pressure operate independent of one another. So let's look at the example of the evening type. An evening type is not able to get to sleep as early as a morning type. So if this individual has to wake up early for work, they will invariably have a sleep restriction that then has them sleep deprived through the week or during their weekdays, and then consequently oversleeping on off days or possibly weekend days. Looking at the graph, this illustrates the problem of the night shift work scenario. So if you follow principally what's delineated in red as the wakefulness of our circadian rhythm, you notice that during our sleep time, wakefulness is rising, and then during the work shift, wakefulness is actually declining. So this is a significant issue. So let's look a little bit more into physiology of sleep. And our sleep cycles last approximately 90 minutes, and that's what's illustrated here in this graph. And this is just an approximation. And you may have heard of REM sleep versus non-REM sleep, where REM stands for rapid eye movement sleep. And curiously, this aspect of our sleep is actually increasing as the night passes, so it predominates by the morning, and it occupies about 25% of our sleep time. Our brain activity is highest during this phase of sleep, but the body is paralyzed with the exceptions of our breathing and our eye movement. Now, non-REM, non-rapid eye movement sleep, can be divided into 3 phases, the last of which is the deepest, or corresponds to the deepest phase of sleep that we experience. Stages 2 and 3 of non-REM sleep predominate early in our sleeping and then actually diminish as the night goes on. It's an interesting observation that that last or deepest phase of sleep decreases as we age, and there are some significant consequences potentially to this observation. Non-REM stage 3 sleep also occupies 25% of our sleep time, similar to the amount of sleep time taken up by our REM sleep stages. Each of these sleep phases plays a critical role with respect to our health, and some types of sleep disturbance affect one phase over another. Particularly a good example is that of the effect that alcohol and marijuana have on REM sleep. And the effect here is that REM sleep is diminished with use. Another aspect of non-REM sleep is that this is an important phase related to our memory, and that something called memory consolidation is occurring during this time. It's something likened to a process where we take short-term memory and turn it into long-term memory. This stage of sleep is also important in our immune function and our recovery. So let's look at some consequences of sleep deprivation. And I'd like to read a couple of quotes from Dr. Matthew Walker's book, Why We Sleep: Unlocking the Power of Sleep and Dreams, published in 2017. And here are 2 quotes. 1. There does not seem to be one major organ within the body or process within the brain that isn't optimally enhanced by sleep and detrimentally impaired when we don't get enough. And second, the leading causes of disease and death in developed nations, diseases that are crippling healthcare systems such as heart disease, obesity, dementia, diabetes, and cancer, all have recognized links to insufficient sleep or disrupted sleep. Let's look at this graphic from the Sleep Foundation. And what you see is an illustration of the many systems that are affected by sleep deprivation, including mental health. You see diabetes risk increased, obesity increased, a reduction in pain threshold, and so consequent increases in pain, Immunodeficiency, we mentioned that non-REM sleep phases were important in our recovery and in our immune system. Increases in cardiovascular disease risk, as we discussed briefly in regards to what was happening in daylight savings time, and consequences to hormone imbalances, including to testosterone and to growth hormone. Did you know there was a relationship between sleep deprivation and obesity risk? Take a look at this graph from Matthew Walker's book. And from epidemiologic observation, what we see is that sleep duration appears to have an inverse relationship with the prevalence of obesity. You can see the rise of the obesity rate increase substantially after approximately the 1960s, as we see a decline in the amount of sleep we're getting. He also comments in his book that even by age of 3, diminished sleep seems to be able to predict obesity by about age 7. I'd also heard in that book for the first time of this study that was published in 2010 that looked at adults who were overweight, where both of these groups were given calorie restriction as the intervention. One group was allowed up to 8.5 hours of sleep and the other 5.5 hours. Both groups lose weight, but the group that is sleep deprived loses 70% of their body weight from lean body mass. That is, they were losing muscle. Sleep deprivation affects two hormones in particular, one which increases our appetite, referred to as ghrelin, and the other one which makes us feel full, referred to as leptin. And ghrelin increases when we're sleepless and leptin diminishes, so it's a double whammy. It seems to impact our food preference in such a way that we want the sugary foods. Another downside of this is that looking at groups of individuals who were given the option of consuming ultra-processed versus whole foods, typically our intake of the ultra-processed food is of a greater quantity in terms of its caloric burden. So that doesn't help us at all. Something, properly speaking, about the makeup or content of these ultra-processed foods makes us want more of them. In addition, insulin resistance is also made worse by sleep deprivation, and this has consequences to glucose levels. For instance, in our patients with diabetes who will experience an increase in glucose after a bad night's sleep. But so also is this issue of so-called lipolysis, or breakdown of fat for fuel, which is negatively impacted by high circulating levels of insulin, which are also increased after a bad night of sleep. We can look at consequences of sleep deprivation by category, and here is a list from the American Academy of Sleep Medicine. And here are some of these categories: excessive daytime sleepiness, drowsy driving, workplace injuries, impacts on mood that are adverse, including anxiety and depression, impacts on performance, so lack of concentration, attention, longer reaction times, distractibility, fatigue, poor decision making, forgetfulness, impacts on health. So here looking at high blood pressure, heart attack, obesity, and diabetes risk. And here are another set of consequences from Matthew Walker's book: testosterone and growth hormone reductions, immune dysfunction, impacting both our risk to infection and cancer risk, chronic inflammation, dementia risk, mental health disorders, so sleep deprivation affecting seemingly all mental health disorders in an adverse fashion. And lastly, this emotional regulation, that is, your ability of your brain to control those areas of the brain involved in emotion and so-called autonomic activation, are going to be impaired in sleep deprivation. So in regards to this autonomic activation, it's that sympathetic branch, so-called, of the autonomic nervous system, which increases pulse, pressure. This starts to sound a little bit like a panic attack, doesn't it? In regards to what one is experiencing more of in the absence of adequate sleep. And last category, risk of injury. One of the interesting things that I noted from Matthew Walker's book is this consequence of selective sleep deprivation. When you look at non-REM sleep, impairing sleep of this variety affects memory consolidation, as we mentioned previously. And this particular memory type is declarative memory, that is, personal facts, general information. This is the kind of thing, maybe call it your book learning, that is impaired when you aren't getting enough sleep. Another aspect here is maturation of the frontal brain regions affecting cognition and reasoning, and this is of particular importance in the adolescent brain. Now, what about REM sleep deprivation? So a different kind of memory, referred to as procedural memory, is affected here, and this is the kind of memory that is skills related, when you're playing a sport, learning an instrument. REM sleep deprivation also affects memory integration, that is, the way that you take disparate ideas in one's mind and make sense of those things all together. It also affects creativity, problem solving, and importantly, this thing referred to as synaptogenesis. This term refers to the creation of neural networks in the developing brain. So we're talking about in utero and in the infant brain. Selective REM sleep deprivation affects our mood states. Matthew Walker particularly, I believe, referred to this as something like sleep or REM sleep producing overnight therapy. And one of the explanations of this was something like dreaming to forget painful emotions or body reactions associated with adverse events. So how much sleep do we need? According to the American Academy of Sleep Medicine and Sleep Research Society 2015 consensus statement, the answer for adults is 7 hours or more. The AASM website in 2024 included information for children, and this duration here listed includes nap time, and for 4 to 12 months of age, it's 12 to 16 hours. And you'll notice that as you progress along, the sleep requirement decreases. So that by the time you hit adolescence, 13 to 18 years, you're 8 to 10 hours of sleep recommended, which is more than the sleep recommended for adults. So we all have this intuition that sleep duration is of importance, maybe supreme importance. But what about sleep regularity? So here's a study that seems to show that sleep regularity is a stronger predictor of mortality risk than sleep duration. This was published in 2023, a study from the United Kingdom involving more than 60,000 participants ages 40 to 69. They divided the participants into 5 groups, or quintiles, from the least to most regular sleepers. And what they identified was that a higher sleep regularity was associated with a 40% lower risk of all-cause mortality comparing the most regular sleepers versus the least. So what defined regular sleep? Distinguishing between the least and most regular sleepers, they defined this in terms of a sleep window. So if you were going to bed or waking within an hour versus if you were going to bed or waking within a 3-hour window. So looking at this graph, you see the 5 different groups. In red, the least regular versus in green, the most regular, and the precipitous decline in proportion survival between those 2 groups. So what defines good sleep? Here's an illustration from Matthew Walker's website at sleepdiplomat.com. And you see the first category being quantity, which is the intuitive factor. What about the rest? Sleep quality. Now, several things impact sleep quality, like interrupted sleep, how long it takes to get to sleep. This is referred to as sleep latency, or the electric quality of our deep sleep, which is something that's only measured by the electroencephalograms during sleep studies. Quality can also be judged, however, by just asking someone how rested they were after a bout of sleep. When sleep gives you the energy back that you anticipated. This is referred to as restorative sleep. Next category is sleep regularity, which we just got through discussing in regards to the study from the UK. And lastly, there's sleep timing. Now, timing here doesn't refer to regularity, but rather to how well our chronotype fits with our sleep requirements. And as we discussed, there is sometimes a discordance between the hours that we prefer to sleep versus the hours that we have in actual opportunities. So we have tools at our disposal for evaluation of sleep, and these include things like sleep diaries, the single item sleep quality scale, previously discussed at other meetings, and is something like a subjective rating of sleep as poor, fair, good, or excellent. The Stop Bang questionnaire for sleep apnea, found at MD Calc, also freely available on the MD Calc application. The Women's Health Initiative Insomnia Rating Scale, the MEQ questionnaire, or Morningness Eveningness questionnaire, found at qxmd.com, and regards a determination of our chronotype. Now, there are additional tools outside of the scope of our practice, which include things like sleep studies. And a sleep study is typically relegated to the evaluation of people that we suspect have one of the following: sleep apnea, narcolepsy, nocturnal seizures, and PLMD and RBD. PLMD is periodic limb movement disorder and can be described as something like involuntary movements of the lower extremities that affect sleep adversely. And REM sleep behavioral disorder, or RBD, which can be described as something like acting out our vivid dreams. So the number of sleep disorders is extraordinarily large, and if you look at sleepeducation.org, which is run by the American Academy of Sleep Medicine, you'll see this enormous list of sleep disorders. So this list is mostly directed at the providers in our group, and I'll go over some of the following. So beginning with the most common amongst the conditions, insomnia. This actually has a definition, so difficulty with initiating or maintaining sleep despite adequate sleep opportunity for the last 3 months and at least 3 times a week. There are the circadian sleep rhythm disorders. So if you can imagine, for instance, the so-called advanced sleep phase, this might describe an elderly person who's going to bed very soon and waking up very early. There's a delayed sleep phase, then there's shift work and jet lag and non-24, and you've probably seen a commercial on this. Next, obstructive sleep apnea, non-REM partial arousal parasomnias, and the key word here being non-REM, and that includes things like sleep terrors, sleepwalking, sexsomnia, and these occur in the first third of the night. And remember in our diagram of the sleep phases that our non-REM sleep actually predominates early and then our REM sleep later. And so the way that you distinguish the so-called non-REM partial arousal parasomnias from just nightmares is that nightmares happen toward the end of the night when REM sleep predominates, which is usually our dream sleep. Next condition here, restless leg syndrome, short sleep misperception, narcolepsy, PLMD, other parasomnias, which include things like RBD, sleep paralysis, sleep talking. And for a fairly thorough list, I refer you to the AASM website at sleepeducation.org. Okay, everyone. So let's shift gears now and start talking about some things that we can actually do for the people that we're serving. We see on the right side of this slide quick sleep tips from the American Academy of Sleep Medicine. I would recommend looking carefully through those. In addition, here are some additional tips. So in regards to naps, keep them short, less than 30 minutes if possible, and before 3 p.m. Temperature. A drop in core body temperature is part of our circadian sleep signaling. So keeping a cool room helps in this instance. Darkness. So using things like blackout curtains, reduce light sources, including our electronic devices, our phones, etc. Don't look at the alarm clock. That's a light source in addition to it disturbing sleep in other significant ways. Light exposure. So exposure to morning light helps to entrain the circadian rhythm so that you can actually get to sleep sooner. We mentioned these last two factors previously. Caffeine, which we didn't say, has a half-life of 5 to 6 hours. So at the end of 12 hours, 25% of the dose may still remain in you. And remember, this competes with adenosine, and so it impairs or affects sleep pressure. Alcohol fragments sleep, that is, it breaks it up. It suppresses REM sleep, and this suppression of REM sleep is also shared in common with marijuana. So one of the best therapies that we actually have for sleep is referred to as cognitive behavioral therapy for insomnia, and it seems to be better than any pharmaceutical and almost anything else that we can throw at this problem. And it consists of at least 4 different aspects, 3 of which we could substantially practice ourselves. One is referred to as stimulus control therapy, and this regards limiting the time in bed that we're not actually sleeping. So one recommendation is to get out of bed when we've been unable to sleep for 20 minutes or more, and then get back into bed when we're sleepy. There's sleep restriction therapy, and this has the aim of trying to increase our so-called sleep efficiency. That is, how much time we're in bed sleeping divided by the time we're in bed. So as an example, if I'm sleeping a measly 5 hours of opportunity and I'm 80% efficient, that means I only got 4 hours of sleep. So that's a 80% sleep efficiency, not very good. If I'm in bed 12 hours and I can sleep 6, my efficiency is 50%. But either way, the idea is you restrict a person's sleep, say, for example, by an hour, to try and force their body to actually rest during that reduced sleep opportunity. And then as the weeks go by, every week, say, you back off by 15 minutes until the sleep efficiency improves and the person's getting sufficient rest. That's just one way of trying to illustrate this process. These other aspects are relaxation, somatic quieting. This involves a number of relaxation techniques, and somatic quieting is also used in things like panic disorder and involve things like breathing techniques, all of which tend to increase the influence of our parasympathetic system, which I've heard some describe as the rest and digest aspect of our autonomic nervous system. And lastly, cognitive restructuring, which is something that largely would be practiced by some therapist who was qualified in CBTI. I'll mention here supplements, melatonin, and very low dose. This is mostly for circadian disruption, like in jet lag, but the caution here is that as this is an unregulated over-the-counter item, the amount of melatonin actually there can be anywhere from 0 milligrams to 8 times as much as what it says on the package. There are other supplements like magnesium glycinate, L-theanine, GABA, and some of you may have heard of tryptophan as a possibility, but this maybe is more relevant as a dietary source than as a supplementary source. And I would just also suggest examine.com as a resource on supplements of most kinds. So we've come to the end of our overview on sleep as a vital aspect of health. This information is a brief overview of some of my learnings in the discipline of lifestyle medicine. I hope you were able to get something out of this talk, perhaps something you can share with anyone having trouble with sleep. I also would recommend the following additional resources, including websites, videos, and books for those of you who would like to learn more. Thank you for your attention. Until next time.